If given a chance, how would you prefer to die? Perhaps by gun, old age, or just the easiest way. But regardless of our preferences, that remains unpredictable.
And we are the Violet Group. The title of our discussion is End of Life Care. And I would like to show you the table of contents of our report, which is the number one, attitudes toward death and end life planning. The second one is caregiver attitudes toward end of life care. The third is values clarification related to death and end of life care. The fourth one is hospice and palliative care. The fifth is collaborative assessment and interventions for end of life care. The sixth is communication at the end of life. The seventh is psychosocial perspective, assessments, and intervention. The eighth is physiologic changes, assessments, and intervention. And the last one is death. So I would like to meet you, the members of our group. The first one is Olivia Lazaga, Sheila Mapile, Kimberly Martes, Shira Molina, Mark Glenn Padilla, Marian Camille Nidoy, Precious Renz Nones, Danica Ormita, Alfredo Rejun Pimentel, and Sandra Ramirez.
Would you like to hear a story about someone's unusual demise? Well, you gotta stay tuned because this is one of the weirdest ways to die. Let's begin, shall we? Okay, so Alan Pinkerton. He is the owner of the Pinkerton National Detective Agency. That sounds so fancy, isn't it? While this agency specializes in railway theft cases, so a lot of people admire or love Pinkerton because he helps a lot of them. But it is also undeniable that some harbor anger towards him. Well, you might jump into conclusion that someone shot him or caused his death in some gory manner because he owns a detective agency. However, did you know that it was his tongue that led to his death? Yes, you heard it right. It was his tongue that led to his death. How? Well, they say he slipped and accidentally bit his tongue so hard that it caused gangrene and eventually leading to his death. Well, what a nice way to end your life. Anyways, that introduces our topic, which is death or end of life.
So every year, more than a half a million people die, and most of these deaths occur in hospitals. Some deaths occur suddenly. The major of deaths occur after a period of chronic illness, with quarters of all deaths being expected. During this time, people often require ongoing care, which may include end of life care.
Death is inevitable. It is a part of our lives. But most people are afraid of dying. That's what makes end-of-life care very important. What is end-of-life care? End-of-life care is a term used to describe the care or support that medical professionals provide for patients with progressive, um, advanced, or terminal illnesses. It requires an active approach to provide comfort for patients in order for them to improve their quality of life. Nurses provide a specialized care to patients who are approaching the end of their lives. This type of care mainly focuses on improving the quality of life for patients and offering support for their families and loved ones. The primary goal is to alleviate pain, symptoms, and suffering, and also promote the dignity and well-being of the patient as they approach the end of their lives. When we say end of life, we come to think of palliative care. But palliative care and end of life are two different concepts. According to the Marie Curie organization, although end of life care can be included as palliative care, Palliative care is more broader and can last longer than end-of-life care. Having palliative care doesn't necessarily mean that the patient is going to die soon. Some people can have palliative care for years. However, end-of-life care offers treatment and support for patients who are approaching the end of their lives. Death is a very serious issue or topic when we talk about this with older adults. And dahil nga sensitive ang ating older adults, syempre, kailangan is more on therapeutic ang communication natin when we are talking about death with older adults. And when we talk about death, dito natin makikita kung ano nga ba yung mga perspectives nila towards death or kung ano yung mga attitudes na maaaring come out when we try to explore their perspectives in death. And this part of the presentation we will explore the attitudes towards death and end of life planning for older adults. So according to the death attitude profile or yung revised death attitude profile na ginawa ni Wong and Recker in the year 1994, nagbigay siya ng 5 sub-skills regarding a person's attitudes towards death. Itong skills na to, ang approaches to death is parang from positive approach, which is yung death acceptance, to negative approach, which is yung death avoidance or yung fear of death. And here, he provided 5 different approaches when we talk about death. So in your screen right now are the 5 different approaches of acceptance to the death. And naka-arrange ito according to positive to negative. So the first 3 sa taas is yung mga positive na connotations about acceptance of death, and yung both naman sa baba, yung dalawa sa baba is yung negative connotations naman, and we will explain it one by one here sa part ng presentation na ito. So for the first one is the neutral acceptance. From the word itself, neutral, ito yung acceptance of death wherein alam ng isang person na ang death is inevitable. Parang rational siya mag-isip na death is part of our lives. It is a natural phenomenon and hindi siya mapipigilan. And someday, alam niya sa sarili niya na he or she will going to die. For the escape acceptance naman, from the word itself, escape, this is an acceptance wherein a person is parang mas gugustuhin niya na lang mamatay to run or para makalaya sa mga sufferings na nangyayari sa kanya. Mostly is napapanood natin ito sa mga pelikula and mga drama. Like yung, for example, yung son ng isang mother is terminally ill and yung son niya is parang medyo nahihirapan na and he will say na gusto ko na lang mamatay, like something like that. That is an example of the escape acceptance. For the approach acceptance, dito pumapasok yung concept na afterlife. To explain it further, the approach acceptance is mainly the acceptance of death wherein a person is thinking na when he die, he will move on to a better place, which is the afterlife. Parang more on biblical ang approach ng death acceptance na ito. For the fear of death, it is talking about the negative thoughts and feelings about the process of dying as a way of confronting death anxiety. Dito is parang you have to face your fear of death, kaya you have to talk a lot more about it para mas makilala mo kung ano nga ba yung parang dito kasi is parang kalaban mo ang pagkamatay mo. Kaya parang you have to talk about it para mas makilala mo, and then your anxiety will be relieved kapag nakilala mo na nga kung ano yung kalaban mo. Parang ganun yung explanation dito or analogy. Ang death avoidance naman is kabaliktaran ng fear of death. sa death avoidance is iniiwasan mong pag-usapan ang plans mo on your death para ma-reduce yung anxiety mo. For supplementary information, I will share naman a research conducted by Fleming et al. In the year 2016, which focuses or which studied the attitudes and perspectives ng older adults natin towards their end-of-life care. And according sa study, most of the respondents, which are older adults greater than 95 years old, are ready to die, reflecting their concerns regarding quality of life. Means na parang they have lived the life they wanted. They are contented with the life that they lived. And being a nuisance, ibig sabihin ayaw na nilang makaabala since older adults na nga sila, they have more needs, and itong mga needs na ito is iniisip nila na parang makakaabala sa kung family members man yan or kung yung caregiver nila. Kaya there are these thoughts na parang gusto na lang nilang to end their life para hindi na sila makaabala pa sa iba. And also, having nothing to live for, ibig sabihin is parang wala na silang iba pang reason to live. Most ng mga respondents na ito is from home for the aged, yung mga wala ng parang wala ng iba pang family members na kasama, or yung parang sila na lang ang nabubuhay mag-isa, and having lived long enough. Since greater than 95 years old na nga sila, is parang na-suppress or na-surpass na nila yung mga life expectancy which is 70 to 80 years old. In this study naman, they have found out that most are not worried about the death itself, but rather they are more worried about the dying process and the people that they may leave behind. So, ang mga respondents natin is parang more concerned kung parang ilan or magkano ba yung magagastos pag namatay sila, or kung mahihirapan ba yung mga people na maiiwan nila kung mamamatay na sila. Something like that.
Let us move on with the discussion and tackle the caregiver's attitude towards end-of-life care. But first, let me define what are caregivers and what is their role in end-of-life care. According to Merriam-Webster, caregiver is a person who provides direct care as for children, elderly people, or chronically ill. So patients undergoing end-of-life care does not only belong to age category of older adults. Some are children or adolescents, whilst a caregiver can be a family, relative, or friend, as long as they are willing to provide care and support to persons who needs assistance, especially persons at the end of life care. Person who is undergoing end of life care might need assistance from caregivers, but not all. So, some people undergoing end of life care wants to be alone and make the best out of their lives. Those people who can still do their activities of daily living. So, caregiving in the end-of-life care needs more than just practical caregiving skills. They need holistic care skills, especially in emotional and spiritual aspect. So, caregivers contribute in providing a quality of care that can greatly influence a death with dignity. So, the care given must be in a holistic approach. When we say holistic approach, it covers all aspects of a person. So, since it will be affecting the life of the patient, they need to have their greatest satisfaction in their hearts. So, caregivers as representatives, care providers, and guardians of the patients are an integral part of and critical partners in the healthcare team. In many ways, the relationship of the patient and caregiver solidifies into them becoming a single unit of care, and further serves to shape the trust relationship that is forged with the physician as illness progresses. the nurse-patient relationship need to have a good foundation in order to attain and achieve an improved quality of life and satisfaction. So thus, the caregiver's attitude towards end-of-life care directly affects the care given to their patients. So, what are the positive and negative attitudes of caregivers towards end-of-life care? So, what are the do's? We have compassion and empathy, patient dignity and autonomy, effective communication, holistic care, pain and symptom management, and cultural sensitivity. So, what do we mean by compassion and empathy? So, caregivers who approach end-of-life care with compassion and empathy can provide emotional support and comfort to patients and their families. When we say patient dignity and autonomy, caregivers who respect their patients' dignity and autonomy empower them to make decisions about their care, ensuring that the patient's preferences are honored. So, next we have effective communication. Open and honest communication fosters trust between caregivers, patients, and families, leading to a better understanding of the patient's needs and wishes. Holistic care. So, caregivers who provide holistic care consider not only the physical needs but also the emotional, social, and spiritual aspects of the patient's well-being. So, when we say pain and symptom management, we talk about caregivers who are skilled in managing pain and other symptoms contribute to the patient's comfort and quality of life during their final days. When we say cultural sensitivity, caregivers are culturally sensitive, understand and respect diverse beliefs and practices, ensuring that end-of-life care is aligned with the patient's cultural background. So, now we proceed to the don'ts. What are the don'ts in caregivers' attitudes towards end-of-life care? So, first we have avoidance of end-of-life discussion. So, some caregivers may avoid discussing end-of-life issues, which can lead to inadequate preparation and decision-making for both the patient and their family. Burnout and compassion fatigue. So, caregivers may experience burnout and compassion fatigue due to emotional and physical demands of providing end-of-life care, potentially affecting the quality of care provided. So, we have next, inadequate communication skills. Poor communication skills may hinder caregivers from effectively discussing these different or difficult topics, leading to misunderstandings and increased stress for patients and families. Next, we have failure to honor patients' wishes. Caregivers who do not prioritize or respect the patient's wishes may contribute to a sense of powerlessness and distress for the patient and their loved ones. So, the powerlessness or the sense of powerlessness is discussed previously by other groups. So, we know that already. So, next we have ethical dilemmas. Some caregivers may face ethical dilemmas such as conflicts between their personal beliefs and wishes of the patients or their family, leading to moral distress. Next, we have lack of emotional support for caregivers. So, if caregivers do not receive adequate emotional support themselves, it can impact their ability to provide compassionate and effective care to their patients. So, next, to sum it up, understanding and addressing both positive and negative attitudes is crucial for improving the overall quality of end-of-life care and ensuring a dignified and compassionate experience for patients and their families. Training and support programs for caregivers can play a significant role in promoting positive attitudes and addressing potential challenges. At this slide, let me present also to you the caregiver's attitude towards end-of-life care to older adults. So, caregiving in end-of-life care for older adults is a challenging and emotionally charged responsibility that requires compassion, communication skills, and a holistic approach to address physical, emotional, and spiritual needs. So here we have some of the key considerations for caregivers in end of life care for older adults. First, we have communication. Open and honest communication is crucial. Discuss the older adult's wishes regarding end of life care, including preferences for medical interventions, location of care, and spiritual or religious considerations. Next, we have to keep the lines communications open with the healthcare professionals, family members, and individual receiving care to ensure everyone is on the same page. So we need to have collaborative assessment or collaborative care for the patient or the focal person. So next we have palliative care. When we say palliative care, it focuses on relieving symptoms and improving the quality of life for individuals with serious illnesses. It is not limited to hospice care and can be provided alongside curative treatments. Seek the support of palliative care specialists who can help manage pain, discomfort, and other symptoms. Next, we have advanced care planning. We need to encourage the older adults to complete advanced directives including a living will and durable power of attorney for healthcare. This ensures their preferences for medical care are known and respected. Discuss end-of-life care preferences with the person receiving the care and their healthcare team. So next we have emotional support. So providing emotional support for the older adults and their family is crucial also. The end of life can be a time of reflection, and individuals may experience a range of emotions including fear, sadness, and anxiety. Consider involving a therapist or counselor to help the individual and their family cope with the emotional challenges. Next, we have respect and dignity. So, treat the older adults with dignity and respect, encourage autonomy, and involve them in decision making to the extent possible. So, next, we have to pay attention to cultural and spiritual preferences as they can significantly impact the person's sense of well-being. So, next naman is we have comfort and pain management. So, we need to ensure that the individual is as comfortable as possible. This includes managing pain effectively through medications and other interventions. Next is we need to collaborate also closely with healthcare professionals to monitor any changes or to address any changes in the individual's condition. So next, we have family involvement. So involve family members in the caregiving process and decision making. Family is crucial for both the caregiver and the person receiving care. Encourage open communication among family members and address any conflicts or concerns that may arise. Self-care for caregivers. So, the care or self-care for caregivers is also a crucial part. So, as I have said a while ago, we need also to look after or to look or to assess their health status to in order for them to provide the quality of care that the patients need. Caregivers need to prioritize their own well-being. Seek support from friends, families, or support groups. So, consider respite care to take breaks and avoid burnout. Understand that grief is a normal part of the caregiving process and it is important for caregivers to address their own emotions and seek support if needed. End of life care for older adults require comprehensive and compassionate approach that respects the individual's preferences, ensures their comfort and dignity, collaboration and health with healthcare professionals, and a support network can enhance the quality of care provided during the challenging time. So, at this juncture, let us discuss the additional topic, which is the comparison between caregivers and nurses in terms of the following listed on the slide. So, we know that caregiving and nursing are two distinct terms or two distinct words but often interconnected aspects of end of life care. So, the difference between training and the education of caregivers and nursing is that caregivers may not necessarily have formal medical training. They are often family members, friends, or hired professional who can provide non-medical assistance with the activities of daily living such as bathing, dressing, feeding, and companionship. Some caregivers may have received basic training in caregiving skills, but they are not licensed healthcare professionals. So usually in the Philippines, we have commonly consider our family members as our caregivers. So, on the other hand, nurses undergo formal education and training in nursing schools or programs. RNs or registered nurses and licensed practical nurses or LPNs have a more comprehensive understanding of medical conditions, medications, and treatment plans. They are licensed to perform medical tasks and administer medication. So, let us proceed to the scope of practice between caregivers and nurses. So, caregivers primarily focus on providing emotional support, companionship, and assistance with daily activities. They may help with mobility, transportation, meal preparation, and household chores. Caregivers often work closely with the family and their families to enhance the overall quality of life, while nurses have a broader scope of practice that includes assessing, planning, diagnosing, or maybe doctors are the ones who diagnose. However, nurses has also their own diagnosis, which we call nursing diagnosis. So next we have also nurses implements medical care. They can administer medications, monitor vital signs, provide wound care, and coordinate with other healthcare professionals. Nurses play a crucial role in managing symptoms, ensuring comfort, and addressing medical needs. Next is we have the difference between medical tasks of caregivers and nurses. Caregivers generally do not perform medical procedures or administer medications beyond basic over-the-counter medications or those prescribed for routine use. They focus on supporting the patient's emotional and physical well-being without engaging in complex medical interventions. So nurses are trained to perform medical tasks, administer medications including pain management, and carry out procedures such as wound care, managing medical equipments. They collaborate with physicians and other healthcare professionals to implement and adjust care plans. So lastly, we have the difference between the emotional and spiritual support provided by caregivers and nurses. So caregivers often provide significant emotional and spiritual support, offering a compassionate presence and addressing the psychosocial needs of the patients and their family. So while nurses on the other hand also provides emotional support but may place a stronger emphasis on the medical and physiological aspects of care. However, palliative care nurses in particular are trained to address the holistic needs of patients, including emotional and spiritual aspects. So, in many end-of-life care scenarios, both caregivers and nurses work together to provide a comprehensive support. So while caregivers focus on non-medical aspects and emotional well-being, nurses contributes their medical expertise to manage symptoms and ensure the comfort of the patient. The collaboration between these two roles is essential for delivering holistic and patient-centered end-of-life care. So that would be all for my presentation. Let us move on to the next presenter.
Value clarification is a process that involves examining and understanding one's personal beliefs and principles, especially in relation to death and the end of life. It helps individuals explore and define their own values, preferences, and priorities when it comes to decision about their own death or death of loved ones. So here is by engaging in values clarification, individuals can gain a deeper understanding of what matters most to them and what they prioritize in end-of-life care. So it helps them to explore their thoughts and emotions surrounding death, which can be a complex and sensitive topic for many people. Next slide is beliefs and values about death and end-of-life care. Vary due to age, gender, culture, religion, and life experiences. So, for example, in some cultures, death is seen as a natural part of life and is openly discussed, while in others, it may be considered a taboo topic. Age can also play a role as a younger individuals may have different perspective on death compared to older individuals who may have experienced the loss of loved ones or confrontations with their own mortality. And gender can also shape beliefs about death as a societal expectations and roles can influence how individuals perceive and handle death. And lastly, the life experiences can greatly impact beliefs and values about death. So next is the caregiver should think about their own values when caring for dying patients because their values can affect their decisions and actions. So here is when caring for dying patients, caregivers should indeed consider their own values. Our values shape our beliefs, attitudes, and behaviors, and they can significantly impact the way we provide care by reflecting in our values. We can better understanding our biases and preferences which can influence our decisions and actions towards the patients. So next slide is the ethical dilemmas are more likely when the patient and caregiver have very different values. So, in ethical dilemmas can arise when the patient and caregiver hold contrasting values because it creates a conflict in decision making. When individuals have different perspectives, is morally right or wrong. It can be challenging to reach a consensus on the best course of action. So lastly, the understanding the values of others is essential for providing good and of life care. Even when they don't have the same values as the caregiver, understanding the values of others is crucial for providing good end of life care because it allows the caregiver to respect and honor the individual's personal beliefs and preferences. Even if the caregiver does not share the same values, it is important to recognize that each person has their own unique perspective and experiences that shape their values. By understanding and acknowledge these differences, the caregiver can provide care that aligns with the individual's wishes and helps them to feel heard and respected. So this is the hierarchy of dying person's needs based on Maslow theory. So first is the biological and physiological integrity. It refers to the most basic level of needs that a dying person requires. This includes the fundamental physical needs such as air, water, food, sleep, and shelter. It also encompasses the need for medical attention, pain management, and comfort measures. Meeting these needs ensures that the person's overall well-being and survival. So next is safety and security. Is the second level of needs for dying person. It refers to the need for protection from harm, danger, and threats. This includes physical, safety, emotional, security, and the sense of stability in their environment. Providing a safe and secure environment for dying person can help alleviate anxiety and promote a sense of comfort. So the third level is the belonging and attachments. So it refers to the need for social connection, love, and a sense of belonging. When facing the end life, individuals of the seek emotional support from harm loved ones desire to feel connected to others. So fourth is self-esteem and self-efficacy. It involves feeling valued and respected by oneself and others. So self-efficacy, of the other hand, refers to the relief of one's own ability to cope with challenges and achieve goals. So lastly, self-actualization and transcendence are the highest levels in Maslow's theory, which a theory that explains human motivation, the order in which they are typically fulfilled. So both self-actualization and transcendence involve personal growth, fulfillment, and a deeper understanding of oneself and the world.
So, ang ire-report ko today ay about hospice and palliative care. So, hospice care provides support for people in the last phase of life-limiting illness through expert medical care, pain, and symptom management, and emotional and spiritual support so that they may live as fully and comfortably as possible. So, however, the palliative care naman is, according to WHO, palliative care focuses on reducing or relieving the symptoms of a disease without attempting to provide a cure. So, it neither hastens nor postpones death. So, next slide po para mas maintindihan po natin ang differences and similarities ng hospice and palliative care. So, sa palliative care po ay isang specialized medical care para sa mga taong may serious illness gaya ng cancer o heart failure. So, ito yung mga pasyente na may nare-receive na mga medical care and also to cure their illness. Sa madaling salita, ang palliative care ay para ma-enhance ang care by focusing the quality life for the patient and also to their family. So, nakakatulong ito sa anumang stage ng sakit and it is best na ma-provide ka agad ang palliative care after ma-diagnose ang pasyente. In addition, nakakatulong ito sa mga older adult. So, kung saan sila ay may maraming karamdaman o discomfort. However, ang hospice care naman ay nakafocus sa care, comfort, and quality of life, kung saan ang isang tao na may serious illness o sakit ay ito yung mga approaching sa kanila ng end of life. And at the same time, hindi siya possible na ma-cure yung illness. Kaya kadalasan hindi na gugustuhin nyo o pipiliin ng pasyente na mag-undergo pa ng mga treatments. So, gaya ng palliative care, ang hospice care ay nagpro-provide ng comfort, gaya ng family support sa pasyente, pero ang hospice ay natigil na ang pag-cure ng kaniyang sakit. So, kadalasan ito ay ang mga doktor na naniniwala silang nasa 6 months or less na lang ang buhay nila. And mas better na malaman nila kaagad tungkol sa hospice care sa pasyente and ng kanyang family. So, para makapag-start na silang makapag-ready and having a quality time with them. Next slide ay ang mga goals ng hospice and palliative care. So, ang mga goals ng hospice care ay manage pain and any other symptoms that cause discomfort and distress. Create a comfortable environment for the patient. So, dahil pwede na silang makauwi sa kanilang mga bahay o kaya kung gusto nilang mamasyal with their family for their quality time, and also allow the patient to be close to family and loved ones during dying process. So, give relief to the patients, caregivers, kung saan makakapagpahinga na rin o mas kakaunti na lang ang gagampanan ng kanilang caregivers and also the nurses. Syempre. And then, yung lastly, offer counseling for the patient and those close to the patient. So, kinakailangan ma-explain natin sa kanila yung mga expected outcomes ng hospice care. Then, ang goals naman ng palliative care is first, relieve pain and other symptoms. Second, prevent suffering dahil andito tayo mga nurses, doctors, caregivers, family to help na matreat ang kanilang karamdaman. Next, address emotional and spiritual concerns of patients and caregivers, and honoring patient preferences and also coordinating care, and lastly, improving quality of life during illness. So, hanggang sila ay gumaling.
Collaborative assessment and intervention for end-of-life care. So, collaborative assessment and intervention is an approach to healthcare that involves a team of professionals working together. It is to assess a patient's need, develop a care plan, and provide ongoing support. For example, this could include doctors, nurses, social workers, therapists, chaplains, and other specialists depending on the patient's needs. Because the team doesn't just jump into treatment, they first work together to comprehensively understand the patient's situation. So here are the assessment needed for the end-of-life care. So the first one is patient interviews, which is done at the end of life because the decisions about treatment and care should ultimately respect the patient's wishes and values. Open and honest communication allows the patient to express their concerns, fears, and hopes for the future. This empowers them to participate in decision making and ensure their care aligns with their preferences. Next is family interviews. So sometimes the patients might not be able to fully communicate their wishes or may be too frail to engage in lengthy discussions. So the family members can bridge this gap and provide information about the patient's unspoken fears, values, and desired level of intervention. So the next one is symptom assessment. So using standardized tools to assess symptoms such as pain, nausea, and shortness of breath. So the accurate assessment of symptom severity and characteristics helps healthcare professionals identify the best treatment options for managing those symptoms. Next is psychosocial assessment. So, evaluating the patient's emotional, social, and spiritual well being. End of life care aims for emotional, social, and spiritual well being alongside physical comfort. Understanding the patient's social network, family dynamics, and access to resources enables the team to connect them with appropriate support systems. So, here are the interventions needed for end of life care. The first one is symptom management, then psychosocial support. It addresses the emotional, social, and spiritual aspects of illness and dying. You could provide counseling, anxiety or depression management, and spiritual support to help patients cope with fear, grief, and other emotional challenges. It is also you can also strengthen the social connection through family support groups or community resources. Next one is family support. So you could recognize the emotional and practical challenges families face during end of life care. It provides emotional support through counseling, bereavement groups, and respite care services. And it also offers practical help tasks like transportation, childcare, and managing finances. It also ensures that families can cope with the emotional and logistical burdens of caring a loved one at the end of life.
Okay, so our next topic is communication at the end of life. So, end of life communication includes both verbal and nonverbal messages that transpire following a diagnosis of a terminal illness and death. The circumstances that occur at the end of life create opportunities for unique and important communication, according to Maureen P. Kelly, 2016. Communication at the end of life can be crucial to convey in first, seriousness of the illness, second, expected course, third, treatment options, risks and benefits, fourth, empathy, support and caring. It also helps in decision making, advanced care planning, and aid in alleviating pain and distress. So the objectives of communication at the end of life can be first demonstrate skills in communicating with seriously ill patients and families. Two, be able to break bad news and respond to the needs of the patients and families. Three, clearly and honestly address the concerns of patients and families. Fourth, know the consequences of the language used to impart information. Fifth, demonstrate skills in communicating to facilitate decision making. Six, demonstrate communication or communicating in such a way that hope is not destroyed, yet avoid providing false hope. Seven, demonstrate empathy and caring both verbally and non-verbally. Eight, demonstrate sensitivity to culture and religious beliefs. Nine, demonstrate skills in communicating in special situations such as over the phone, with other professionals, or with family members far away. So the goal of communication at the end of life can be first convey respect and understanding for the patients as a person, convey information about illness, likely course and treatment options. Third is convey empathy and support. Fourth is convey enough or appropriate hope. Fifth is develop a treatment plan in context of person's value history. Six is arrange follow-up and ongoing care and support. Next, we will be tackling about the barriers to communication at the end of life in terms of patients and family, healthcare system providers, and healthcare system. So first is we will talk about the barriers due to patients and families can be because to first, misunderstanding, second is biases, third is lack of knowledge of death, fourth is realignment of family roles, fifth is lack of support, coping mechanisms, crises, six is physical and emotional depletion, seven is strong emotions, eight is differences in values, beliefs, and culture. Next is barriers due to healthcare providers can be because of first is depth of relationship with patients, Second is fear of uncertainty in diagnosis or prognosis. Third is personal and professional experiences with illness and death. Fourth is fatigue, psychological and emotional stress. Fifth is fears of own mortality. Six is lack of education. Seven is fear of emotions. Eight is personal beliefs, values. Nine is bias. 10 is fears of being messenger. 11 is iatrogenic complication. 12 is unrealistic expectation of success. And 13 is inconsistent approach or mixed messages. Next is barriers due to healthcare system because of first is time constraint, size of practice, lack of previous relationship, lack of privacy in hospitals or clinic hospice, and fourth is interruption. Next will be the 9-step approach to communication at the end of life. So first is to start the meeting. Make sure that it is quiet and private place. Avoid having conversation at the hallways, doorways, or communal waiting room. Also sit. The next is introduce the team and explain roles to the patients and family. Also ask the family to introduce also themselves and explain relationship to the patients. Then builds relationship with patients and family. Next will be agree on purpose. This one is to update the family, to break bad news, to discuss a decision point, and to provide emotional and psychological support. Next is what do they know? So in this part, we are going to assess the patients and the family about their thoughts or beliefs about illness. Assess also the language used, the level of understanding, the misconception or the misinformation, the time of last update or information retained, understood, and emotional state or coping abilities. Next is to what information is necessary or needed for decision making. Some of those are the diagnoses, likely course or prognosis, treatment alternatives, risks or benefits, effect on quality of life, goals, values, beliefs, expectations and fears, pain and symptoms palliations, expected and anticipated decision, and dying process, location of the death, available healthcare support. We are also going to share the information like in a simple and a clear way. Use a language or terms that is appropriate to their level of understanding and show empathy and compassion. At the same time, we are also going to discover the goal, hopes, expectation, and their fears, address their needs, develop a plan, do a follow-up. Also take note to avoid using jargon term, using a language you would use with a colleague, euphemism, provision of false hope of cure or greater likelihood of benefit, and inappropriate distraction of hope. Okay, so before I'll end my discussion, let's do first a reflection time. So now, think about your own parents or grandparents' love. How do they make you feel special? How do they show their love and kindness? Take a moment to share your thoughts with a friend, family member, or teacher. And let's celebrate the unique love.
I will be discussing for today is the psychosocial perspectives, assessments, and interventions. Under the psychosocial perspectives, we have the emotional well-being, understanding and addressing emotional aspects like anxiety or sadness. Example, providing a platform for emotional expression. So I did the research and found something that the United Kingdom uses. This is what they call the Silverline Helpline, a free telephone service just for older people. Silverline Helpline gives anyone age 55 or over the opportunity to exchange a friendly word, access support, or enjoy a long enriching conversation. Next will be social connections, recognizing the importance of relationships. Example, facilitate visits from family and friends, organizing virtual meetings to maintain connections, facilitating communications through technology. You can also organize family gathering to enhance social support. Another example is physical interviews. Physical interviews facilitate a deeper understanding of older adults' social connections. Physical interviews with older adults can provide valuable insights beyond what may be conveyed verbally. Observing their body language, mobility, and overall physical condition can offer cues about their health, cognitive function, and general well-being. Additionally, in-person interactions allow for a more holistic understanding of their living environment, social support, and daily challenges, contributing to a more comprehensive assessment. Next is spiritual considerations, respecting and incorporating spiritual beliefs and practices. Example, creating a peaceful environment for meditation or prayer. Acknowledging their spirituality can enhance the overall support provided. It fosters a sense of cultural competence, helps address emotional existential needs, and contributes to a more holistic approach to their well-being, providing connection between their spiritual identity and overall health. Next is the psychosocial assessments. Under the psychosocial assessments, we have the mental health evaluation, assessing for signs of depression or anxiety through standardized tools like the Geriatric Depression Scale. The Geriatric Depression Scale, or the GDS, is a widely used screening tool designed to identify depression in older adults. It consists of a series of yes or no questions related to mood, satisfaction with life, and physical well-being. The scale helps healthcare professionals assess and monitor depressive symptoms in elderly individuals. Next is the coping mechanism assessment, identifying how the individual copes, discussing and encouraging the use of effective strategies such as journaling or art therapy. Another example is music. Music is also a part of relaxation techniques, so engage them in a meaningful or creative activities. Next is social assessment. Determine the patient's network of social support, determining if there are any sources of assistance, isolation, or strained relationships. The last topic that I will be discussing is the psychosocial interventions. Under the psychosocial interventions, we have the counseling services, providing emotional support through counseling, using techniques like validation therapy to acknowledge and validate the person's feelings. Next is support groups, facilitating participation in groups for shared experiences. For example, involving the older adult in a support group for those facing similar end-of-life challenges, encouraging family members to join caregiver support groups. Next is palliative care for holistic support, offering comprehensive care addressing physical, emotional, and spiritual needs. For example, implementing palliative care services that include pain management, symptom control, and emotional support, involving interdisciplinary teams for holistic care.
End-of-life care, physiologic changes, assessment, and interventions. End-of-life care is a specialized form of a care that is provided to individuals who are near the end of their lives. This care is designed to manage physical, emotional, and spiritual symptoms and to improve the quality of life for both the patient and their loved ones. End-of-life care can be provided in a variety of settings, including at home, in a hospital, or in the physiological changes. Physiological changes, generally speaking, people who are dying need care in four areas: physical comfort, mental and emotional needs, spiritual needs, and practical tasks. Of course, the family of the dying person needs support as well, with practical tasks and emotional distress. And the assessment aims to help dying patients and their families planning clinical interventions in advance and prepare them for a peaceful end of life, in which the patient accepts life and death. The family accepts the patient's departure. And the interventions. Interventions is we need to listen to the patient and their family members, communicating with members of the interdisciplinary team and advocating for the patient's wishes.
Our last topic is all about death. Sabi dito, dying is a process. It involves the cessation of physical, psychological, social, and spiritual life here on earth. Then, merong dalawang primary responsibilities ng nurses at this time. Una ay ang providing symptom management and preparing the family for what to expect as death is approaching. So, ang mga nurses rin ang mag-aasikaso regarding sa organ donation, postmortem care, and facilitating arrangements. So, next slide. Lahat tayo ay may mga sariling paraan sa pag-cope up sa pagkamatay ng mahal natin sa buhay. So, the following strategies can help caregivers provide the support to the family through this experience. So, una ay ang discuss. So, discuss the family's wishes early. So, dito is pag-usapan lang ang mga gusto ng pamilya na mangyari. And then next is record and communicate instructions on who to call, how they can be reached, and whether there are any limitations regarding time of day. Then next is offer family members at the opportunity to participate in the care of the dying person. Kasi gusto ring makatulong ng family members regarding sa pag-aalaga. And then next is allow family members to express their emotions and provide them with support. Merong mga ilang family member na hesitant and kailangan nila ng permission para i-express ang kanilang mga emotion, pero meron ding iba na hindi. So, ensure lang natin na they feel comfortable and supported. And then, next is provide frequent updates on the condition of the dying person and be available to answer questions. Families often need assurance that the person is comfortable, and then provide comfort measures and be sensitive to the needs of the family members. And then next slide. So we have here the Kubler-Ross stages of dying. So meron tayong mnemonics na DABDA. So ang una is D, which is denial. It is the first shock of receiving the diagnosis is the start of denial. Patients frequently respond to the news that they have a fatal illness with outright denial and disbelief. Patients could look for second opinions or occupy their time with activities and distractions. Dito ay sasabihin ng patient na baka nagkamali lang or simply dinideny niya na meron siyang sakit. And then next is anger. Denial is usually followed by anger. So the prognosis is no longer negotiable and the patient starts to accept the diagnosis as true. Anger or even wrath may follow this revelation. The person could be frustrated or resentful of the circumstances, asking themselves, why me? They can start acting grumpy or depressed. They might start arguing more or maybe start abusing drugs or alcohol. And the next is B, bargaining. The patient enters the bargaining stage as they try to delay death while accepting the terminal diagnosis even more. The patient engages in negotiations at this phase. Frequently, these discussions are held with God. So the patient might attempt to negotiate, offering to take action in exchange for changing the final result. So these commitments could center on a course of treatment or lifestyle modifications. During this phase, the patient may experience fear or shame and frequently have spells of concern. And the next is depression. So the patient enters the depressive stage if attempts at bargaining are unsuccessful. Mourning is what defines this stage. In addition to lamenting their past losses and suffering, the patient also grieves for the losses they will experience upon passing away. Desperation can arise from things like lost experiences, lost time with friends and family, lost health, and others. A depressed sufferer could feel helpless and overwhelmed. Their sleeping and eating patterns can alter. It could become clear that you're lacking in vitality and social connection. So it's normal to turn away guests at this point. The patient may cry uncontrollably at times and may use alcohol or drugs as a coping mechanism. And then last is acceptance. So the acceptance stage is the last one. The patient is no longer fighting death's inevitable outcome. He or she has come to terms with the situation's reality and the terminal diagnosis. In this stage of their illness, patients frequently exhibit serenity. They don't show a lot of emotion and frequently ask to be left alone. When they do talk to people, they could seem to be completely in the present and have open discussions regarding the circumstances. So the patient might talk about finalizing funeral plans, offering counsel to close ones, or doing last-minute tasks. And the next slide is recognizing imminent death. So, some physiological changes may indicate approaching death pero hindi mapipredict ang exact moment or oras ng pagkamatay. So, these are some indicators of imminent death but are not limited to. So, these are the following. Number 1 is increased sleepiness, then decreased responsiveness, confusion in a person who has been oriented, hallucinations about people, sometimes this is family members, then increased withdrawal from visitors or adult social interaction, loss of interest in food and fluids, loss of control of bowel and bladder in a person who has been continent, altered breathing patterns such as shallow breathing, rattling or gurgling respirations, and then involuntary muscle movements and diminished reflexes. So next slide is the signs of death. So una is absence of heartbeat and spontaneous respirations, open eyes without blink, and then non-reactive pupils. The next is flaccid jaw with slightly open mouth and lack of response to touch, speech, or painful stimuli. And then last is the legal pronouncement of death is made by the physician. So meron tayong mga things to remember. So if family members are present when the patient expires, they should be allowed to sit at the bedside and say farewells or grieve as long as necessary. And then allow the deceased person to remain in the room if other friends or family members who were not present at the time of death wish to assemble. And then perform post-mortem care in accordance with cultural and spiritual preferences.
End-of-life communication is essential for assuring the dying's dignity, autonomy over their concluding wishes, and tranquil closure. It has the potential to facilitate genuine dialogues, restore emotional distress, and enable individuals who are nearing death and their loved ones to construct final recollections. Enhancing communication with healthcare professionals can result in improved outcomes for terminally ill individuals and their families, including increased satisfaction with end-of-life decisions, pain management, and mourning and bereavement support. Hospice volunteers and professional caregivers have the opportunity to gain insight into the significance and intricacies of end-of-life interactions that impact society as a whole.